Thank you for that wonderful introduction. I'd like to express my gratitude for the organizers for inviting me to take part in this year's Congress. It's quite an honor to have scientific exchange with international colleagues. I have a limited amount of time and a lot of slides to get through, so I'm going to go fairly quickly, but there are three main areas to my talk today. One is the pharmacotherapy of alcohol withdrawal. The next is the pharmacotherapy of alcohol dependence. And then I'm going to spend some time talking about neuroimaging and alcohols, in particular some of the work that we've done to elucidate craving in the brain and also medication treatment of those brain areas. I do want to acknowledge the fact that I am involved with a variety of different pharmaceutical companies and received grant funding from them, also in some of the speakers' bureaus, and also received funding from NIH, that being NIAAA and NIDA. Now, as a background to the talk, I think it's important to talk about the actual prevalence of alcoholism. In the United States, we're looking at around 18 million people meeting criteria for abuse or dependence. About half of these are alcohol dependent. And the important point here is this is the same prevalence that we see with other disease models, such as asthma, diabetes, and depression. And alcoholism is a very costly disease in the States. We're looking at about $134 billion a year that this disease costs us. Most of that is in terms of a loss of productivity. And certainly alcoholism affects many other disease processes, whether it be liver disease, certain types of cancers, hypertension, coronary artery disease, etc. So it's very important that we actually recognize this as a disease process and efficiently treat it and effectively treat it. There's an incredible gap, though, between this high prevalence of alcoholism and what actually we see in treatment. If you think we have actually 18 million people out there with abuse dependence in the States, only about 1.2 million are seeking treatment. Then if you look at that 1.2 million, there's a huge gap in those that are actually receiving a pharmacotherapy. And most when we think about alcoholism treatment, we think about a psychosocial treatment. But then again, there are very effective medications that we'll talk about that are out there. So when we talk about addictions treatment, well, usually it's two phases. First, we have to safely detox the individual, and then we provide relapse prevention. Now, when it comes to detoxification, really the gold standard for alcohol withdrawal treatment has been to substitute in a benzodiazepine. If you look at any of the textbooks, that'll tell you exactly what we were supposed to do, and then we gradually taper that benzodiazepine over 4 to 7 days. All the benzodiazepines are effective. They all have different half-lives, etc., but they all are effective for the treatment of alcohol withdrawal. We then supplement with vitamins and minerals, particularly with thiamine, folic acid, and the multivitamin. We provide supportive treatment. But one thing that is increasingly clear is that the treatment of alcohol withdrawal is becoming much more of an outpatient procedure versus an inpatient procedure. And that has led to some concern because as we all know, the benzodiazepines do have abuse liability. And therefore, if you're giving an abusable substance to a person with an addiction then to go home with, that can be problematic in certain patient populations. There's been quite a bit of clinical lore over the years that benzodiazepines can prime alcoholics back to drinking. In other words, increase their likelihood to go back to drinking again. And there have been some animal models that would suggest that that is indeed true. However, there's been very little clinical data. In fact, one of the only studies that you can find on this, very interesting study design, it was double-blind, placebo-controlled diazepam versus placebo. They had 12 heavy-drinking alcoholics, and they told them they're going to take part in a taste test of 3 different beers. This taste tests were a week apart. Before one of the tests, they gave them 5 milligrams of diazepam. Before the other gave placebo. And what they found is that when people were benzodiazepine primed during this taste test, they drank more during the taste test. They rated their craving for alcohol higher during the taste test. And paradoxically, this finding I think is quite interesting. They had a computer screen and they flashed up alcohol-containing words and neutral words. And when you have the diazepam on board, you can more quickly press that you recognize the alcohol-containing words. Because of the fact that we do have this abuse liability and many more outpatient detoxes are becoming outpatient, we became very interested in looking at alternatives to the benzodiazepines for detoxification back in the 1980s. The advantages here are, of course, the fact they have no abuse liability. They are anti-seizure medications. they're neuroprotective, and during alcohol withdrawal, there's a phenomenon that occurs called kindling, where each episode of alcohol withdrawal seems to get worse, and people actually begin to have more and more neuronal damage. We know that the anticonvulsants are anti-kindling agents. And lastly, benzodiazepines are cognitively impairing. And when we do have that case to get someone on the inpatient unit, that's our first hook that we can have to get them into the next phase of treatment. If we give them a benzodiazepine and they're kind of asleep most of the hospitalization, well, we lose that important hook. So certainly the anticonvulsants are less cognitively impairing. Disadvantages, limited clinical experience. As a matter of fact, I think Europe has probably the most experience in looking at the anticonvulsants in this capacity. Some people are also concerned about the hematological side effects, particularly liver toxicity of some of our older anticonvulsants agents in a vulnerable population as far as their liver function. Now, in the essence of time, we have nice data sets with valproate, carbamazepine, gabapentin, tiagabine, etc. But I want to focus on two of the studies that we've done that I think are particularly important. The first is carbamazepine versus lorazepam. This is a large double-blind trial sponsored by NIAAA, 136 patients that meet criteria to come into this study. You had to have a certain alcohol withdrawal symptom level. We measured that by the Clinical Institute Withdrawal Assessment. Essentially, that's just alcohol withdrawal symptoms. And you had to have a greater than 10 on the scale to come into the study. We had two different, a 5-day tapering dose of carbamazepine or lorazepam. Now, a previous study that we published had found that really carbamazepine will be equal to lorazepam in treating alcohol withdrawal symptoms. We published that back in the late 1980s. What we're interested in this particular study is what effect would this anticonvulsant, this anti-kindling compound, have on those individuals with multiple alcohol withdrawals. So we broke our group into those with very little detox experience, 0 to 1 prior detoxes, and those with greater than 2 detoxifications. And what we found is that it didn't matter what group you were in or what medication that you were on. Alcohol withdrawal symptoms came down exactly the same. So both medications effectively treated alcohol withdrawal. But we did something different in this study. We had people come back in. Again, it's 5 days of treatment. We had people come back into the lab on day 7 and day 12. So 2 days past detox and a week past detox. And we looked at a variety of different things. And one of those was return to drinking. What you see here, this is drinks per drinking day. And if you were on carbamazepine in the single detox group, you're drinking about 1 drink per drinking day after detox. Those on lorazepam in the 0 to 1 group were drinking about 2 drinks per drinking day. But here's your group that had multiple alcohol withdrawals. And what we found is that if you'd been treated with lorazepam during detox, you're drinking a little over 4 drinks per drinking day, whereas those on the anticonvulsant were drinking about 0.3 drinks per drinking day. And there are a variety of other symptoms that back this up, too. If you look at sleep, both groups came in complaining of poor sleep. Well, during the actual detox on medication, sleep improved in both groups. But as soon as you stopped the benzodiazepine, sleep plummeted again in the benzo group, whereas it remained stable in the anticonvulsant group. The next medication, this paper is, I think, just been accepted to ACER. This is gabapentin versus lorazepam. The advantage of gabapentin is it does not have any liver metabolism, therefore is very safe to use in our alcohol population. Again, double-blind, over 100 patients. Again, the same inclusion criteria, C over greater than 10. Tapering doses of 900 milligrams or 1,200 milligrams of gabapentin, and lorazepam with 6 milligram tapering down over 4 days. Now, as a proxy of CNS excitability, we also did acoustic startle at baseline, day 4 and day 7. And again, when we looked at their drinking at follow-up days on day 7 and day 12. If we look at just their alcohol withdrawal symptoms, to be honest with you, these medications effectively treated alcohol withdrawal no matter which one. We did see in lorazepam a little bit of a jump up after medications had declined in the alcohol withdrawal symptoms, but they all were effective in treating alcohol withdrawal. There's a little bit of statistical significance for gabapentin, 1,200 milligrams over lorazepam, but clinically, I don't think that's very meaningful. But what is meaningful, again, is when we looked at a variety of measures. I'm only going to show you one, whether it was sleep, it was anxiety, etc. They all favored, in the post-detox period, they favored the anticonvulsant. But the biggest thing is if we look at the odds of drinking in the follow-up period. Remember, both of these studies have been outpatient treatment, so people had easy access to drink. we find that both doses of gabapentin significantly decreased the odds of return to drinking after detoxification. So this is all I want to say about alcohol withdrawal, but I will add one comment. When it comes to treating just mild to moderate alcohol withdrawal symptoms, my own personal preference is to use an anticonvulsant. Now, if someone has a history of seizures or DTs, at that point I usually double cover them. In the States, that actually buys you a hospitalization. You can come in for detox. It's very difficult to get people in for detox. You would probably have to have suicidal ideation, have a significant medical problem or history of seizures or DTs. At that point, I will double cover with both the benzodiazepine and the anticonvulsant. One of the things, acoustic startle on these patients, a good proxy measure of CNS hyperexcitability. And we can see in the gabapentin group, this is day 0 at baseline, that increased startle, but on day 4 and day 7, startle came down significantly. And these people, if you can see, this is a control group. The people on gabapentin looked much more like the control subjects. Whereas you look at the lorazepam group, they really never separated out from day 0 to 4 to 7 and never came down to looking like the control group. In other words, more CNS hyperexcitability in that group. Now, switching gears over to the treatment of alcohol dependence. I'm not going to spend a lot of time showing you data. I think we all have heard about these medications. We know they work. I wouldn't be up here talking about them if there were not studies out there suggesting that they were effective. So we're going to just briefly go over them and give some pointers or predictors of who might respond to each. The first agent, disulfiram, or antabuse, is strictly an aversive agent. What we're trying to do here is have this alcoholic understand if they drink or ingest anything with alcohol in it while on this medication, they will have a significant reaction and actually can die from the medication. This does nothing to the brain chemistry involved in craving, etc. It's strictly an aversive agent. Next we have naltrexone, probably the agent we've done the most work with, opiate receptor antagonist. It really blocks the high of use for the most part, and that's what a lot of the alcoholics will tell you, is that the drinking just doesn't taste as good. Now, if we look across studies with this medication, what we find is a decrease in drinks per drinking day and a decrease in heavy drinking days. And heavy drinking days are probably the most important factor here, because heavy drinking days are most correlated with outcome as far as accidents, medical comorbidity, etc. So again, we're not a great drug to get complete abstinence, but a great drug in cutting down on alcohol use. Next, acamprosate or Camprol. I think the rest of the world were using acamprosate much sooner than we were in the States. It came to us very late. It's a glutamate modulating agent. And the thought here is this medication really works by decreasing those protracted withdrawal symptoms. When we all think about alcohol withdrawals being that phenomenon that lasts for the first 5 to 7 days after someone stops using alcohol. However, for weeks to months afterwards, these patients complain about a variety of symptoms. They can't sleep very well, they're anxious, they're moody, and they're irritable. And a lot of this is probably a glutamate-mediated phenomenon. It's thought that this medication might help decrease those protracted withdrawal symptoms and therefore decrease relapse to alcohol use, and maybe also decrease cue-induced craving. A study has been out there that's shown that. And lastly, one of the factors that we found in a lot of our work with naltrexone is that, well, you have to take this medication if it's going to work. In other words, when we look at our trials, we like to see that at least 70 to 75% compliance is there before we will find an effect. So now there is an injectable, a month-long injectable naltrexone that is available, and certainly aids with compliance. Now, as far as predictors of response to disulfiram, and this is really a summary of a lot of work that's out there. We know that individuals with high motivation, those individuals that are married, those individuals that have behavioral contracts to actually take the medication, and those that are legally bound to take the medication do very well. Again, if the medication is not on board, it's really not going to work, since it's an aversive agent. We also looked at targeted treatment. In other words, when someone has been out and sober and off alcohol for a while, but they're going to go into a very high-risk situation where they might be exposed to alcohol, we can use targeted treatment on those individuals before they go to whatever that situation might be. but if you look at all the double-blind trials that have been done with disulfiram, rarely have they really completely panned out from placebo. It's only when it's witnessed that the person ingested the medication is when you see a nice separation out from placebo, and it actually makes a lot of sense. And how we typically use it is having a spouse, significant other, have them take the medication and watch them ingest it. Now, as far as naltrexone, we have even more data on who might actually respond to naltrexone. We know those people that get the most benefit are those individuals that are doing it, are taking the medication in conjunction with some type of psychosocial program, particularly involving cognitive behavioral therapy, those with high levels of craving when they come into the clinic, again, those with higher compliance, again, at least 70-75% compliance on the medication, those individuals with a family history positive of alcoholism. Also some lab data, we've had some of this at our site, is that lower baseline plasma beta endorphin levels and an exaggerated response to alcohol challenge. But really, this is where the future is with naltrexone right here. And this is the single nucleotide polymorphism on the 118 receptor, the opioid receptor mu gene. It seems that individuals who have this certain SNP are more responsive to naltrexone. The problem with this SNP is it only occurs in about 20 to 25% of Caucasians, about 1% of African Americans. So when we look overall at our results for naltrexone clinical trials, where it's not getting this incredible robust effect across the board, it might be because we really have to select out who those individuals are. In fact, we're in the process of recruiting for a very large trial, selecting out individuals that have this SNP, and looking at those individuals on naltrexone versus placebo to get a much better understanding of this interaction. And we're all of a sudden going backwards on this somehow. Okay. Here we go. The injectable naltrexone, one great trial that's out there by Garbutt and colleagues, a 6-month randomized, this is 6 monthly injections versus placebo injections, a variety of different dosing strategies. This is the dosing that's actually FDA approved. They found that this 380 milligram injection had a 25% reduction in heavy drinking days, whereas the 190 had a 17% reduction in heavy drinking days. Males in pretreatment absence had a greater treatment effect in this particular population. I will tell you that clinically we're using quite a bit of this injectable naltrexone, and it's really working well. Matter of fact, all the clinicians at our VA clinic, they're actually requesting that their patients get put on the injectable for the compliance reasons, actually seeing that it is working for them. Now, camprosate. The biggest advantage of a camprosate, in my opinion, is the fact that it's not metabolized by the liver. Therefore, it doesn't induce the cytochrome P450 system. We don't have to worry about drug-drug interactions. Particularly important maybe in dual diagnosis patients on a variety of other medications. It's probably excreted unchanged by the kidneys. Again, we can use it in combination with disulfiram or naltrexone using hepatic impairment, and there's been no evidence of any abuse or dependence liability. This particular medication, I think, is really great for our individuals who have lower levels of craving maybe and endorse these protracted withdrawal symptoms. Now, probably the best trial to talk about as far as the effectiveness of these medications is the combined study. This is a large trial that we were involved with, 16 weeks of treatment, almost 1,400 individuals over 11 sites in the United States. A very complicated study design. There are actually 8 groups. These groups receive either medication, medical management, or combined behavioral intervention. A little bit on medical management. All medical management really is telling people they need to cut down on their use, at every visit asking what their use was like, and really trying to have them be compliant with the medication. So it's not something we typically think about as an approach that we would take with therapy with a patient. Now, combined behavioral intervention is a much different thing. It really was the best of all worlds. It was motivational enhancement therapy, cognitive behavioral therapy, etc. It was all the bells and whistles that we can do as far as alcoholism treatment. Then also 2 different therapies and then 4 medication groups. Naltrexone 100 milligrams, camprosate 3 grams per day, the combination of the 2 and placebo. And going into this study, I think everyone thought that this combination would do the best. And there was a 9th group here that really received only CBI. Now, in essence of time, I've really cut to the chase. The bottom line was that naltrexone worked best in conjunction with the medical management in this particular study. And unfortunately, camprosate did not separate out from placebo, which many of us find fascinating considering we use this medication and find it to be quite effective. There's been many thoughts about maybe the patient characteristics in this study, that they were not the ones that might respond to camprosate, and the deck was kind of loaded against it in the beginning, etc. But I think the take-home thing is that medical management is something anyone can do in any clinic, a primary clinic, a family medicine clinic, etc. So now we know that at least naltrexone, along with that very basic type of therapy, can be effective. So in comparing the safety of these medications, certainly when we think about safe to use during relapses, we know we cannot use disulfiram. However, both of these medications have been found to actually decrease the amount of drinking during a relapse compared to baseline, so we should actually keep them on the meds during a relapse. As far as safe for use in hepatic impairment, really only camprosate here should be used in people with significant hepatic impairment. And we look at some other subtle factors, such as drug-drug interactions. Well, certainly with disulfiram, any alcohol-containing preparation, whether it be mouthwash, dinner cooked with wine, etc., can give you, even cutaneous alcohol can give you the disulfiram reaction. We always ask that any patient placed on the medication also have to sign a behavioral contract so they understand what these things are or not. Now, as far as naltrexone, opioids, opioid-containing products. Now, that's been quite problematic for us in some of our patient populations with the high comorbidity with either pain or opiate dependence. So you really have to be careful here. You can actually, especially with Vivitrol, the extended release naltrexone, you really need to get a urine drug screen for opiates prior to beginning that injection. We've had at least one case that I know of where even though someone asked, are you taking opioids or opiates, the person said no. They injected them and they went into Florida opiate withdrawal because they just were not truthful. As far as the camprosate, we do not have any known drug-drug interactions. Contraindications with disulfiram, of course, any hepatic cirrhosis, insufficiency with naltrexone, renal impairment, opioid dependence, acute hepatitis, liver failure. With the camprosate, really only severe renal impairment. Possible severe adverse events. Several with disulfiram, most notably really the peripheral neuropathy is what we'd actually see. With naltrexone, hepatocellular injury or liver failure, none known with a camprosate. Now, at this point, I'm really going to take a jump off into some, I think, very exciting data, which is the use of neuroimaging in alcoholism. And I want to begin with kind of the basics, is what is fMRI? That's the neuroimaging technique that we use at our site. And really, fMRI is a way that we can infer neuronal activity based on blood flow. And the hypothesis here is increased neural activity equals increased oxygen demand, therefore more blood flow going to the area. And really, in fMRI, we're taking advantage of the fact that with oxygenated blood, it's diamagnetic, whereas deoxygenated blood is paramagnetic. So we need this on-off phenomena so we can see the differences between these two types of oxygenated, deoxygenated blood, and this gives us our MR signal. Now, as a very simple task to show you, this is actually finger tapping. This is actually me, a single individual in the scanner, doing 10 seconds of tapping my right hand, and then 10 seconds of tapping my left hand. So there's an on-off phenomena going on in both hands. And what you actually see here is contralateral activation of the motor strip in a single individual, giving that on-off phenomena. So whenever we think about this work, we have to have some type of on-off phenomena. Now, what is the importance of imaging research, particularly in alcoholism? Well, it really can help aid in our understanding of what's going on in the brain during craving. That's the paradigm that we're interested in, is craving. Also can aid in the evaluation of potential medication treatments and aid in the understanding of neurobiology of relapse. I'm going to hit all three of these areas. So the standard methodology now is that we have to give a cue, something that's going to have this alcoholic think about alcohol and crave alcohol. But we're going to have to do this in a very unnatural environment, that being an MRI environment. So a variety of things that we can do. We can show them pictures or video. We can have them handle paraphernalia. This is particularly enforcing in cocaine users or crack cocaine users. We can do imagery, we can have odors, or we can do a sip or an infusion at the same point in time. The magnet's running, we're getting our craving ratings, images are being obtained. Now, in our particular paradigm, we use two different cues. We use a picture cue and a sip cue. And this is what it looks like. So we have blocks of alcohol-containing beverages, of neutral beverages being coffee, tea, milk, etc. We have visual controls, which are just these pictures that have been blurred so you can't tell what they look like, and we have a rest condition. Each of these blocks is shown for 24 seconds. And during those 24 seconds, 5 pictures will come up that's specific to that block. So in the alcohol block, there might be 5 pictures of beer, etc. Now, in between these blocks, there's a 6-second rating scale where you rate your urge to consume alcohol for the picture blocks that you just saw. Now, before we show this really a 12-minute randomization of these blocks of pictures, we give 5 cc's of alcohol. It's essentially a taste, a priming taste before they see the pictures. Now, since we need this on-off phenomena, our dependent variable of choice here really is the alcohol minus beverage condition. In other words, we're summing up all the brain activity of people looking at the alcohol pictures and contrasting that to the brain activity when people are looking at the neutral beverage pictures. It's a great contrast because you drink both of these, but one of them has the alcohol in it. So this first study was published back in 2004, and I've just kind of cut to the bare parts on it to look at our subjects. Basically, these are non-treatment seeking alcoholics. They meet the DSM-4 criteria for alcohol dependence or abuse. They meet the loss of control measure, and they're drinking at least 20 drinks per week. Now, we also have social drinkers that have never met criteria for abuse dependence. They're consuming less than 14 drinks per week and less than 2 drinks on any one occasion. So they truly are social drinkers. There's a nice contrast between the two. Again, if we look at just, these are 10 subjects in each group. If we look at just their drinks per drinking day, you can see those alcoholics are drinking about 8.2, the controls drinking 2.2. So clearly a big difference in their drinks per drinking day. Now, if we look at the take-home message here, this is our 10 alcoholics. Here's our 10 controls. You don't have to be a neuroscientist to see some very big differences in the brain activation. And we see that classic addictions pathway activated in our alcoholics. In other words, we have this bilateral ventral striatal activation, we have bilateral insula activation, and we have anterior cingulate activation, which we don't see in our controls. And if we go a little bit further back in the brain, we have the ventral tegmental area also activated that we don't see in the controls. I think this is very important, and we use this a lot in our addictions treatment programs to actually show this to the patients, to let them understand, listen, something's very different in your brain when you see those beer commercials than in someone who's not alcohol dependent. Something different starts happening in their brain. So what can imaging tell us about treatment? Well, we know from animal models that cues can stimulate dopamine release, and from the imaging models, we also know that same areas, the ventral striatal areas, activated when people see cues. We've seen this in our pattern and some other imaging studies that are out there. So dopamine stimulation could potentially reverse or block this cue-induced ventral striatal activation, and blunting of this ventral striatal activation could actually reduce craving and relapse behavior. So this next study was just published back in 2008 in the Archives of General Psychiatry, where we want to explore the effects of combining medications on altering cue-induced brain activity in non-treatment seeking alcoholics. We have 4 medication groups here. We have naltrexone, which we talked about. We have ondansetron, which is a 5-HT3 antagonist that's also been shown to have potential blocking dopamine activity. We have the combination of the 2 medications, and we have placebo. Essentially, we treated these non-treatment alcoholics for 7 days on medication, and then we did our standing imaging paradigm that we just saw. Here's your demographics and drinking characteristics. To note, this is a very large imaging study. All of the treatment blocks had at least 20 subjects. Our social drinking controls had 17 subjects. But really, I think we should pay attention to this. This is drinks per drinking day. 11 in naltrexone group, almost 10 on ondansetron, a little over 8 in the combination group, and 9 in placebo, and then only 3 in our control group. So, and again, a big difference as far as the drinks in the past month in the treatment groups compared to the control group. And what we found is this, pretty impressive, that the medications naltrexone, ondansetron, or the combination actually could attenuate this ventral striatal activation that we found in the placebo group. Again, 7 days of medication attenuating the ventral striatal activity. What's also, just for me as a researcher, that's nice is that these were done on 2 different scanners. The first study I showed you was on a 1.5 Tesla. This is on a 3 Tesla with a different data software technique. And again, we still robustly get this ventral striatal activation with our paradigm. And again, these medication groups look much more like our social drinking group. Now, if we look just at this ventral striatal activation, we can see, very high activation in placebo, a significant decrease in naltrexone, even further significance if you look at the combination group. Again, very little activation in the social drinking controls. Another area in this study that we became very fascinated with is the medial prefrontal cortex. What we can see here is in the social drinkers, we had no medial prefrontal cortex activation. On placebo, we did find this activation. However, naltrexone seemed to attenuate that prefrontal activation. Next, what about other medications? Aripiprazole is a partial dopamine agonist that we've been increasingly interested in. Some open-label data suggested it might be efficacious in the treatment of alcoholism. There's a multi-site trial in which we were involved with that found a decrease in drinks per drinking day with the medication. A clinical lab study by Hank Kranzler found a dose-dependent reduction in euphoric effects of alcohol. I will mention one other thing about this multi-site trial. They tried to dose up to 30 milligrams per day, and really that was too much. Now that we're learning much more about aripiprazole with the treatment of depression, etc., we know we need to be much further south of 30 milligrams. And so therefore, we are actually using a much lower dose in our next studies. And again, maybe if we can block this ventral striatal activation, we can actually decrease craving and decrease relapse behavior. Our typical paradigm that we use, the demographics. We can see the drinks on these individuals are about 10 drinks per drinking day in both the placebo group and the aripiprazole group. Again, non-significant differences between our two in a variety of age and drinking parameters. And again, we found this in the placebo group, this ventral striatal, this is more around the nucleus accumbens, ventral striatal activation, a little bit of insular activation that was attenuated with aripiprazole. I'm going to take this a little bit further. We just broke the blind on another trial. This is 7 days of treatment with 15 milligrams of aripiprazole. We truly wanted to look at what impact would this have on the drinking. So we just broke the blind, placebo versus aripiprazole and a social drinking control group in which we treated for 14 days. And we dosed up again in the first week to 15 milligrams. Therefore, they were on 15 milligrams for a week before we did the scanning. And we looked at their drinking over that same period of time. And again, this is really rough because I just got the data. But just in the essence of time. Again, we find in the placebo group, we get this nice ventral striatal activation that we, again, attenuate on aripiprazole. Again, we don't see any in the social drinking group. But the main finding here is we also, against non-treatment seeking alcoholics, we got a drinking effect. We had a decrease in heavy drinking days and increase in percent days abstinent after 14 days of drinking. And unfortunately, we couldn't get the data together enough to tell you if this means anything as far as that drinking. But that's what we're doing right now, is trying to correlate this attenuation in ventral striatal activation with the actual drinking. So what can imaging tell us about relapse? Now this is unpublished at this point. We just finished this trial about a month ago. 7-week randomized control trial. These are treatment. Now this is our first foray into treatment-seeking alcoholics. We have 48 here. We scanned these people 10 to 21 days after they started medications. This is in a 3 Tesla scanner. We used our Q induction paradigm. We haven't finished all of our data analysis at this point in time. But one thing is very interesting that we've already looked at. We collapsed the whole data together. This is all of the alcoholics. And the areas of activation that differ between alcoholics who did and did not relapse, well, the medial prefrontal cortex was activated in those individuals that relapsed. which was not in those that did relapse. Again, we're getting more and more focus on the medial prefrontal. Our previous focus has really been on ventral striatal area, because we might think out of the box and think of other ways we might be able to impact the medial prefrontal cortex, maybe with TMS or a few other ideas that we could have. One quick thing before I wrap up: interpreting neuroimaging literature. If anyone has looked at this literature before, you know that we have a variety of different findings. We all might study alcohol or cocaine, but maybe we're not all getting ventral striatal activation. We could be getting amygdala. We could be getting anterior cingulate. We could get other brain areas. Well, that's really the reasons why that we have different findings. First of all, we use different techniques. We use PET, we use SPECT, we use fMRI, and that's a little bit of difference in the craving, how you might obtain it. Also, we use different cues. I use a combination of two. Some people use odor, some people do infusions, etc. But also something that's important, I think, is length of abstinence. If you're scanning someone right after they stop drinking, certainly the way they think about alcohol might be certainly different than if they're a month or 2 months from the last drink of alcohol. And also alcohol expectancies. What are they thinking about alcohol? Do they want to drink? Are they treatment seeking and resisting when they see these pictures, not wanting to drink? So all these really go into interpreting the literature when you're looking at it. So in conclusions, we are very excited about this idea of anticonvulsants in the treatment of alcohol withdrawal. It's really beginning to take shape in the States, and a lot more people are beginning to use it. We're starting to do more and more outpatient alcohol withdrawal. Certainly we need to follow up and do another gabapentin study to actually prove that it is a very effective medication. I know it's the one that I predominantly use when I do outpatient detox. And I think it's very favorable that with the medication that we use to treat alcohol withdrawal can impact their return to drinking. That already gives us a little bit of leeway before we actually start a medication just to help them stop drinking, that we can have them sober at least for a while. As far as the treatment of alcohol dependence, we do have medications that are out there. They are effective. I don't think that we know exactly how to use these medications. In other words, there might be genetic subtypes that might preferentially respond to different meds, particularly around the SNP and the opiate receptor gene and naltrexone. I mean, we might be getting further to that day when we actually can take a drop of blood, put it on a chip, and it will tell us exactly what alcohol medication the person might respond to. The neuroimaging data, I think, is going forward in the future where we need to be with all these meds. In the past, we'd spent a lot of money doing large clinical trials, multi-sites. I think we can use neuroimaging in lab studies to get data on medications to find out if they might be effective before we actually go down that very expensive and time-consuming process. And our data really are consistent with the animal data as far as ventral striatal activation to cues and also the medication effects that we have on that ventral striatal activation. So I think it's a very novel and useful tool to further explore alcoholism and alcoholism treatment medications. In the end, any of you who do research know that you don't do it in a vacuum. There are a lot of people that are involved in the work that I do, and some of those are listed on this slide. Ray Anton, Xingbao Li is responsible for a lot of our data analysis, Scott Henderson, Pat Randall, Constantine Veronin, and Mark George, and also I'm very fortunate to have received funding from both NIAAA and the Mental Health Service Line and our VA Research Center. Thank you very much, and any questions?